Hi, everybody. My name is Robin Bethel, and I'm really excited to be talking about a subject that I find very important, and actually the most important subject when it comes to orthodontic success with clear aligners. This is a presentation that I gave at the Las Vegas Gallerite Reunion Convention, GRC, in 2018. I had a lot of good feedback and success, and I'm really happy to share it to whoever wants to learn from it. The things that I think are most important about this topic is, anybody can do this. I live in Texas, and in Texas, dental assistants and dental hygienists are very limited to how they can impact patient clinical outcomes. In Texas, for example, assistants can't really do much of anything. No doing fillings like my Washington peers, and hygienists can't even give injections thanks to Texas legislation. But they can drive clinical success with orthodontics because they can do everything digitally. They can scan, take records. They can even do a Clincheck, which is a 3D software offered by Invisalign to design orthodontic cases. So I'm really excited to teach this subject to everybody that wants to learn. Even patients who are interested in Invisalign can kind of see how the sausage is made, for lack of a better term. And yeah, I'm going to be posting this as much as I can, and any feedback I get, emails, comments, whatever, I'm going to answer and respond to and be as helpful as I can. So the name of this presentation is called Crushing Clinchecks, and it's a systematic way to view, edit, and produce Clinchecks that are predictable. And I'm going to jump right in. And I'll start by introducing myself. My name is Robin Bethel. I graduated from the Arthur A. Degoni Pacific School of Dentistry in 2007. I was Invisalign certified. 2006, Dr. Boyd certified me, and then I got out of school, started practicing in San Diego, and then lost my Invisalign status and switched to ClearCorrect for a while, did some bracket and wire. A lot of my good friends are orthodontists, and they helped me out a lot. I am the owner of Forest Family Dentistry in Austin, Texas, and I'm extremely proud and honored to be the owner there, and I love my team. They're part of my family. I'm also a father of 3 boys and an amazing wife and family. I have gotten my claim to fame by being really high on Yelp and we call it CSI, or customer satisfaction. I think that the thing I've done the best in my short career so far is develop culture that is focused on taking care of people, patients that are I see as my own family as well. And we've been able to grow significantly over the last 3 years. I can be found on Instagram. Our team can at Forest Family Dentist, and our side project is called Simply Aligners, and I lead that project with my partner Michelle Straight, Dr. Straight, and she is a diamond level awesome Invisalign provider, and we're able to really give excellent outcomes predictably to people in Austin. Anyway, a lot of this presentation is inspired by my mentor. His name is David Galler. Dr. Galler practices in Manhattan, and he is a phenomenal resource and advisor to me. And a lot of his foundation is what built what you're about to learn. And if you can, join the American Academy of Clear Aligners, which David is the president of as well. Anyway, enough about me. I want to show some pictures here. For one, this picture on the lower right, you'll notice that's me in 2012. And I don't look like that today. I got a lot more gray hairs, a little chubbier, a couple kids. Take away some sleep. But that's the Instagram image of who I am. And people see me present. They usually see that picture because it's, frankly, the best looking picture of me. And I know dentists on Instagram will post their trophy cases, their best looking work. I'm not here to talk so much about my best work. I'm here to talk about my day-to-day practical outcomes and how to get predictability every single time you use Invisalign. So Sometimes you get excellent trophy cases, you show them off, and sometimes you don't. There's my family. It's what Instagram sees. Kids are happy, smiling, professional photographer. My wife posted this on Instagram. We look so good, so happy. Yet, day to day, sometimes life hands you a big old turd. That's my son, and he literally handed my wife a turd. That's reality. And something I hear all the time is, how do you pick good cases, and how do you make Invisalign easy? Well, the reality is there's really no such thing as an easy case, because an easy case can be attached to a human that has some difficulty, some complexity. Sometimes people aren't compliant. Sometimes the smallest detail can drive a patient crazy, and they don't comply, and the success is not what you want it to be, even when it looks like the Clincheck is simple. And the reality is we as practitioners have to be able to navigate those waters, and we don't always get the perfect Instagram success story. We want to just make it so that the predictability goes up. And I know that in dental world, dentists love showing off their best work, and I feel like there's this divide between the hygienists and the assistants, and that sometimes assistants, because they can't show off the clinical success and they don't have as much power in dictating the outcome, I feel like they get a little jaded and they don't get to show off these trophy cases. My encouragement is that you start to learn these things, and you can start showing off incredible results and feeling like you had an impact on people's health. I know, in fact, that people don't feel like they are that empowered and feel like great about their work because I looked up hashtags. That's how I know. And the hashtag I followed up on and searched for is Dental Assistant Life on Instagram. And it was pretty revealing. The top 3 search results: number 1, dental assistant 8 a.m., dental assistant 5 p.m. Looking pretty rough. The Pam Anderson meme. And I feel like a lot of assistants feel like that someday. They work really, really hard. They sometimes don't get the praise and the patient's love and success. And so they feel like they go home looking like Pam Anderson. Pro facing your head, don't care. The number 2 result from dental assisting worldwide: Sunday night is here again, another night of laying in bed wondering what fresh hell awaits me in the morning. Just rough. And lastly, I know a lot of my team can relate to this because they like hip hop, listening to songs about selling drugs and killing people and the weight of a 9 to 5 job. And if you feel like this, you're not alone. And this is a reality. Some dentists feel like this too. And I just am here to say that in 2018, this is my bold statement, it's the best time in the history of the world to be a dental professional. We can drive clinical success digitally. Dr. Gala gave a presentation with Joe Hogan at the conference in Las Vegas in July, and Joe Hogan got on stage and said that they are continuing to invest in the general dentist, the provider. I know because I look at 50 to 100 Clinchecks a week and do so much Invisalign. I know how skilled you have to be to drive success. I'm not worried about the future of robots taking over this. I also know that patients' health is vastly improved when they align their teeth. I believe that there's nothing more impactful I can do for my patients' health than align their teeth. We all know that we feel like broken records. We see patients every 6 months. We say the same things over and over. You got to floss more. There's always tartar here. There's inflammation. We take photos. And I've seen my patients completely reverse periodontitis, gingival disease by aligning teeth. You prevent abfraction, you prevent tooth wear when you align the bite right, but you got to know what you're doing. These direct-to-consumer products, 90% of the time, do not improve the bite or periodontal status. I have cases I'll show at the end that show that they actually can harm them, and they have to have a professional intervention in order to fix the damage done by these direct-to-consumer products. So I think that the solution to the future, the problems with clear aligners, and clear aligners are amazing, is a expertly trained dental profession. And I'm here to give clues and tips to make you and your team better prepared. So we're going to jump right in. This is the meat and potatoes part. This is crushing Clinchecks. And want to start by saying that my goal here is to help my doctors find average adult cases that are just 20 aligners, require no revisions, and patients are in and out successfully in 20 to 30 weeks. I found that after 40 weeks, patients start to lose interest, they get bored, they get tired. If you start to revise, clinical and emotional success goes down the tubes. And there is no substitute for a well-planned Clincheck. You can have the most compliant patient in the world, and if you don't have a Clincheck that conceptually makes sense and your theory is sound, it will not be successful. The difference between loving Invisalign and not loving Invisalign is understanding the Clincheck. So I want to help you learn the most valuable controls with Clincheck Pro and how to make predictable movements. I want you to learn to understand, I call it the Clincheck cartoon, and the cartoon is just that. It's a movie that shows the forces that are going to be applied to teeth. And I want to show people what those forces mean and how they translate in reality to your patient. And I want you to only accept predictable Clinchecks. Don't accept the first thing you get back from Costa Rica. Invisalign's algorithm is good, but it fails 90% of the time. If you just trust the initial algorithm, you're going to have a lot of failures in your practice. Dr. Galler advertises he can do Invisalign with no revisions 80% of the time. It's an incredible result. The national average dentist and orthodontist has a 150% revision rate. And that means that every patient goes through 1.5 revisions. So they have to go through Invisalign 2 to 3 reboots. That's not successful. We want 0 reboots. So we want to make it so you accept only predictable outcomes. And second to poor compliance, accepting a bad Clincheck ruins predictability. Let's move on. So when you first start submitting Invisalign Clinchecks, you look like my favorite actor, Keanu Reeves, in Bill and Ted's. Just, whoa, I can't believe that's going to happen in the mouth. You signed up for Clear Essentials, and the cartoon makes the teeth look straight. All you had to do is submit an impression, take some photos, and boom, you look like a hero. Unfortunately, that's a naive perspective. And that's like Bill here. Doesn't know what's going on. I can't believe it. So let's talk about what Invisalign and what Clincheck is. So Clincheck is just a user interface. That's all it is. I have a Clincheck I'm going to be referencing today. This is a patient of mine. I just got this back. You can see the date on it. I got it 2 days ago. We're going to go through this together. All Clincheck is a user interface with a bunch of controls that's going to help me design a Invisalign case. The techs in Costa Rica are your support team. They help you understand the algorithm, and they try to translate your wishes to the software. They do not know your patient. They do not know what is best for your patient, and they are not orthodontists or dental professionals. Most of the time, English is a second language, so they're not going to understand your wishes on the first go-around. Clincheck is not anything that cares about your patient, anyone. It is just a piece of software that has a really incredible, constantly improving algorithm, but it needs to be led by a dentist. Success and failure of your Invisalign case is your responsibility. If it fails, it's not Clincheck's fault. It's your fault for not understanding how Clincheck works. And that's a really big thing. And a lot of people get very jaded with Invisalign, and they blame the plastic or they blame the Invisalign. I can tell you this year, of the 400 cases I start, 399 of them are going to end successfully, improving patient outcome. Maybe one patient will fall off and not come back or move or lose interest, and that happens. You can't control that. But it's my success and my failure. And taking that responsibility is the first step to really understanding this. All right, so let's go in. So when you get a Clincheck back from Costa Rica, I'm going to give you the systematic steps to understanding the Clincheck and viewing it. The first step, always when you get a Clincheck back after you submit it, you view the animation. You watch the cartoon from different perspectives. This is how I do it. I look at it from a front view. There's this little button right here. You click that, and I slide the bar. Why? Because I'm impatient and I don't want to wait for the animation to go through. And you look at it. All right, I see what's going on here. Got some blacked out laterals, upper twos. We got a Div 2 presentation where the centrals are pushed back. You know, in the patient's mouth, they probably really don't like the shadows that are cast on their central incisors. They don't like that these laterals look so skinny and you can see daylight. I see a lot of attachments on the case looking from the side. You know, slightly class 2 on the lower right. Excuse me, the lower left. Right side, same thing, slightly class 2. And looking from the upper view and watch the animation, a little bit of expansion, lingualizing the laterals, a lot of IPR. The bottom, not much happening, just a little bit of crowding. Pretty straightforward case, right? All right, so step 2, after you've watched the video, you go to mentally categorize the Clincheck. We were doing that, I was doing that out loud, but this is where you apply your skill as a technician. A, what kind of case is this? Is this crowding? Is this spacing? Is it a deep bite? Is it class 1, class 2 skeletal? Is it marked by difficult movements? Does the Clincheck adjust the patient's chief concern? Does it look good? Aesthetically, is this result an improvement? And you're going to have to look at the patients. I'm going to show these photos here. This is what the patient's teeth look like. I know what this patient's face looks like. I'm going to protect her identity here. But I know what the teeth are going to look like in the end and the lip position and the lip line. Is my result going to improve her aesthetics? I call it the Holy Bible, the Grail of Invisalign, to dictate whether or not it's a simple case. Dr. Galler and Dr. Ostreicher designed this. It's called the Go Tooth Acceleration Chart. It's an incredible resource and tells us, is the case easy or is the case more difficult based on the tooth movements? Tier 1 movements, we know Invisalign moves teeth very easily, expanding in the premolars or lingually tipping the molars. It buccal and lingual crown tipping very easily. It constricts teeth lingually towards the tongue very easily. It closes spaces, small spaces, very easily. And it proclines and retroclines incisors very easily. If your case is simply doing these things, we call it a tier 1 case, and you can go change aligners very, very quickly. If it's a tier 2 case, you have to change it every week or use an accelerator. There was a great debate on accelerators at the convention in Las Vegas. We brought the 6 most popular accelerators: Accelident, BitePod, Propel, V-Pro, Munchies. There was even an ultraviolet light accelerator that people were talking about, and they had a panel and they showed and they debated the merits to each of their accelerators. I have some favorite accelerators I'll share with you guys. I think they all can work, but there's different implications for each one. Lastly, tier 3. This is when it usually requires lots of prayer, and I think that's true. If you have a lot of tier 3 movements in your case, you're not going to have success, plain and simple. Even with Propel and Wilcodonics and some crazy things people are doing now to soften the bone so teeth move quickly, you're not going to be able to predictably get the outcome you want. Teeth that are difficult movements, they say rotations more than 20 degrees. That's back in 2016. Root torques, that's a big one. Root torques are bad for any orthodontic system in adults. Basically, moving a tooth through bone and torquing a root across the bone, mandibular or maxillary bone, is very difficult. Intruding central incisors or deep bite maxillary central incisors, very, very difficult and hard to retain. And if you're translating a crown to close a space or an extraction case where you try to move a tooth and translate the whole tooth in the root mesially, distally, or buccally or lingually, it's very difficult. And back in 2016, it required a lot of prayer. You had to change your aligners every 2 weeks with 23.5-hour wear. I updated the chart. David Galler set the foundation. I build off of it. Dr. Ostreicher, who's a brilliant orthodontist. Now with Munchies, as a tool I use from EOCA, I can change these aligners every 5 days predictably. Tier 2 movements, if staged correctly and use Munchies, can now be viewed as tier 1 movements. And rotations of tooth more than 20 degrees, I can get that successfully, predictably in my office with Munchies at a tier 2 pace, once every week, changing aligners once a week. The tier 3 movements, I have to isolate these movements and stage them, so I only do that one difficult movement at the end. I use accelerators for it, but I no longer have to pray. I can get predictable results if I set the Clincheck up correctly. Let's continue on. So looking at our case, let's go back to it. There's Keanu Reeves in The Matrix. He's starting to learn stuff. He's learning Kung Fu a little bit. This case right here, I'm looking at it. Any difficult movements? All right, we see that we have to extrude laterals. It used to be the saying was luck the faterals because lateral incisors were very difficult to move with clear aligners. We have attachments everywhere. I can look down here at the tooth movement table. This is the mandible. See the maxilla. On number 7, we're rotating at 26 degrees according to the Go chart. That's a tier 3 movement. And with my Go chart, that's no longer tier 3, it's tier 2. My updated. Tooth number 11, a canine, a long 3-centimeter canine in maxillary bone with 22 degrees of rotation. That can be tricky. And remember, this is the first Clincheck I got back from Costa Rica. Step 3, you need to run through your clinical preferences. This presentation is not so much about theory. There are a lot of different Invisalign theories out there. I've kind of adopted my own based off a foundation from Dr. Glasser, Barry Glasser, who published a book on Invisalign rules. Dr. Galler, who's really my mentor, has shaped my Clincheck. And then Dr. Randy Kunick in Austin, Texas, who I'm a huge fan of, has shared a lot with me. He's an orthodontist, been doing this for 22 years. He's learned a ton. I call him the White Wizard. I have my own theory. It doesn't really matter what your theory is. I mean, it doesn't matter, but I'm not here to talk about that. As long as you have a theory. If you don't have a theory, I'm very happy to share with you mine. The clinical preferences are what you add into your Invisalign chart. I have my clinical preferences. I'm going to show you guys here a little bit, but I'll email them to you if you leave a comment below. Or email me directly, or Instagram, whatever. I'll send you my Clincheck preferences. You got to look at your case. Did your tech read your preferences? Do they apply them to your case? How many aligners are there? If they did 45 aligners, it's going to take that patient at minimum 45 weeks to do their Invisalign treatment. That's too many. Remember, the techs don't always read them. So you have to audit it. You got to run through the clinical preferences, see if they were followed. Here's my clinical preferences. I have a Google Doc I share with people. I'm constantly updating it with new tricks and tips. I literally copy and paste this into my clinical preferences on my provider ID site. I can show you guys how to do that if you want to know more about that. But I'm going to kind of skip through this really quickly. And I want to talk a little bit about Galler algorithm or Galler engine. David Galler created, he's the first to create this, an algorithm. Basically, the way the computer will set up every Clincheck. It is revolutionary. It's only available to about 500 dentists right now. And if you want to get in on the algorithm, which means that your Clincheck doesn't go to your tech, it goes first through a computer program that sets your case up exactly like we want them to, at least close to how we want it to, and then it comes right back to us for us to start editing. It's much faster. Clinchecks come back usually in 24 hours or less after you submit a case from a scan. You got to talk to your reps, and you got to ask them, how do I get Galler algorithm? It's also known as Clinical Preferences North America 1, NA1. They're the first ones to ever use this protocol. It's very different than Invisalign's Assist. It kind of looks like Invisalign Go. I don't know who invented it first. They're very similar looking, but yeah. These are clinical preferences. If you can get on the algorithm, it's definitely my preferred way. Well, let's look at our case. When I look at Invisalign Clincheck, I like these horizontal beveled attachments on all my bicuspids. It's for anchorage. They provide a lot of support. These are specialized attachments. It's called a double spike or optimized root control. It helps torquing roots or translating roots. These are optimized multi-plane attachments. These things have specialized little dimples in them. You cannot control, add, or subtract these. The algorithm adds these to the case. I can add and subtract these ones. I'll get into that a little bit more later. But did it set it up the right way? Well, I know I don't like my cases to round trip. Round tripping is when teeth move one direction, then the opposite direction in the same Invisalign case. There's no round tripping on this case. My molars aren't moving. Only time I move molars is when I absolutely have to. They follow my preferences. This went through the algorithm. It came back to me. I submitted it on the 17th, got it back the 18th. Really cool. So that's going to really help a lot of you out. Step 4, we turn on the tools. This is so important. And utilizing these tools, most doctors don't even know they exist. The tools I like to use the tooth movement assessment tool, the tooth movement table. I look at occlusal contacts. I call it the hot map of occlusion. I look at the photos and I compare the Clincheck. I look at superimposition and I look and understand attachments in IPR. So I'll go over here. The tools are in this little bar right here. You can look, you can add and subtract whatever one. Some people use the grid. It can provide some help in knowing millimeter differences. But I usually look at the occlusion, show occlusion. It shows you where the teeth are hitting. They're in green spots here. I like to look at the tooth movement table. That's this big thing here. This is very, very important in my cases. It is a lot of numbers. It's very intimidating to new dentists. You look at this, like, well, I don't know what the heck 7.1 degrees M means on 25. When you look at rotation, mesial, distal, M means mesial, 7.1 is degrees of rotation. IPR is always on. I want to be able to see where the interproximal reduction is going to be needed. Sometimes the Clinchecks come back with way too much IPR. Sometimes they come back with not enough IPR, and we have to be able to know when to use it and when not to use it. I also look at the attachments. I always want those on. I'll hide occlusion there so that it's more opaque. And for class 1 cases, I look at Bolton analysis. Bolton analysis is Dr. Bolton invented this algorithm. It's really cool because it's done digitally. I don't have to measure models anymore. It says that an upper incisor is exactly 8.32 millimeters from mesial to distal edge. And it adds this up, plugs it through an algorithm. It basically tells you in class 1 if the upper arch or the lower arch is bigger teeth. And it will show you two size discrepancies, and sometimes it's helpful, sometimes it's not. It's showing that from canine to canine, 3 to 3, the mandible has 1.5 millimeters of excess tooth. You know, that's not a big deal for a class 2 case. I'm actually happy that reduces overjet. Anyway. Superimposition is really important because you have to know sometimes the Clincheck will come back and it will blow teeth through buccal plate. I'm going to look at superimposition here. I'm going to look. It looks like the arches are centered basically where they start, over the maxillary bone. I don't have to worry about teeth blowing through buccal plate, overexpanding, over-translating. The lower arch pretty much centered on the arch. I know this is a low risk for causing perio problems because of the superimposition here. Very important tool in my office. So I turn all these on. Let's go back. So they're all turned on. I looked at all the tools. Step 5, the most important. This is when your skills come in, and this is when we have the power to control our Clinchecks. So we got to hit the button, create modification. It's right up here in the upper right. Hit create modification. The modified treatment plan number 1 pops up, and this is when I can control my outcome. Here you can see on this bar on the right, it shows all these vectors of movement. It shows the arch. It says the width, initial, final. This is some tools a lot of doctors use. I don't use it a lot. You have attachments. I use this all the time. It only allows you to use the basic attachments. There are no optimized attachments here. Again, these have to be applied by the algorithm or the text, and they are only applied on teeth that have the required movement. If your tooth has a 5.1 degree angulation, mesial and distal change, that will trigger the algorithm to throw on a double spike attachment. You cannot just ask for a double spike unless that tooth is moving that way. So that's an important thing. The IPR is controlled here. I can click it. You can also adjust it, make it no IPR really simply just by clicking no IPR if you want to. This is all customizable. So that's the toolbar that comes up when you hit modify treatment plan. All right, let's get into the manual controls. This is the fun stuff. This is what I spend most of my time doing. This is where it gets really interesting. So you want to use manual controls as much as humanly possible. And I'm going to drive this point home. Do not leave the control and success of your Clincheck up to a tech in Costa Rica who does not know your patient. Use the manual controls up to the maximum you can. Utilize a tooth movement table. Eliminate unnecessary and difficult movements. This is a very important concept. If a tooth does not need to be moved drastically, don't do it. The patient doesn't care. It doesn't affect their occlusion, their bite. If it doesn't affect their periodontal health, don't do it. Place the allowable control attachments and delete unnecessary ones. I like, and I'm influenced by my good friend Dr. Koenig, I like very, very few attachments when necessary. Patients don't like them. You can see them. If you can do 0 attachments, some cases require 0 attachments, it's great. So let's go back to my controls, all right? So I can start to do things. I have my controls up. I'm looking at this case. The first thing I see is a ton of IPR on the maxilla. IPR is one of the most hated things by dentists and patients alike. It's not a big deal, but it means requiring removal of enamel. And I do it using quick strips and space files. It takes about 30 minutes to do something like this. I have my own tips, the Texas tips I call it, where I can accelerate that a little bit. But I won't get into that too much today. You can ask me questions later. I see a lot of IPR. You know, I want to know what the case would look like with no IPR. So I'm going to go over here. You see no IPR. So if I do no IPR, you can see the teeth translate buccally quite a bit. Can I translate these teeth buccally? It looks like they're retrocline legally. Yeah, I probably can. Do I want to do that a lot? Not so much. In this case, man, I see a lot of interesting things. I see mesially rotated bicuspids. I see now that I've eliminated the IPR, I have overjet. About 3-4 millimeters of overjet, right? Patient may not want that. They started with no overjet, now they have overjet. Maybe I can do things to reduce that overjet. I also notice I have an occlusion issue. I can show my occlusion convex. Now I'm hitting heavy here. So what can I do to fix this? This is a good question. If I don't want IPR in this case, you know, IPR can help, but if I don't need it, I'm going to try not to. And looking at her case, I don't think I need very much. I'm going to go through, I see these are rotated, and they're rotated in a way that doesn't make them skinny. Only reason I want to rotate a bicuspid is it's going to help make the teeth skinny. It's going to help do IPR. So if I manually rotate this tooth, you'll notice that that other bicuspid moves closer. I'm going to do the same over here, and I'm actually going to make the tooth a little skinnier, and I'm going to increase my buccal expansion. Something you can do predictably with Invisalign is expand in the buccal corridor. Not only is it predictable, but it makes the outcome look better. You widen the patient's smile. I'm doing it manually. I'm just dragging it out, clicking it out. Is there a limit to how much you can expand buccally? Yeah, I think 2 millimeters in a case where they're tipped lingually is about the limit I will recommend. Sometimes if they're tipped way in and collapsed in, you can go further than that. Let's see how that looks. All right, so expand buccally, but my occlusion is off. I see lots of extrusions. These are extrusions. I don't like extrusions, and I want to eliminate them if possible. You can already see the extrusions here. I'm causing hyperocclusion on the heat map. I'll double-click on the tooth movement table, and I'll just hit 0, type 0, and hit enter, and boom, it goes to 0. I'm going to do this on every single tooth. Why? Because I want to see what it's going to look like without these difficult extrusions. Conceptually, try to understand if the whole arch is trying to extrude, you have no anchorage, it will not happen. Plastic requires anchorage. At least with our clinical preferences, we do not have movements on the molars. No movements on the molars means molar anchorage, which is really important. So I'm double clicking, I'm eliminating all of these extrusions just to see what it would look like. Let's see, still don't have an open bite, which is good. Let's look at the mandible. Look at that, all intrusions basically. So I was extruding the maxilla, intruding the mandible. Why would anyone do that? That's what the algorithm gives you. It doesn't make sense. You're basically moving the top teeth down and the bottom teeth down. So unless the patient has a really, doesn't show a lot of their incisor, upper incisors, a really poor incisal display, you may want to do something like that, but usually you don't. And I recommend if that's the case, we look at other options. But not orthodontically extruding an entire arch is probably not in the patient's best interest. So I'm going to go in here and I'm going to eliminate the vertical movements on the mandible too. Just double click, get them out of here. And I'm going to go through here and manually do this on every tooth. And then we'll look at the teeth again here. Let's see. How does this result look? Not too bad. Where they started, where they finished, wider smile, no more overlap. I think that angulation on number 7 is a little off still. Let's see if we can fix that. We have a 12-degree distal tipping on number 7. Let's just zero that out. Let's see what it looks like. That's a very difficult thing. You know, don't love that angle, but I can maybe meet in the middle. How about right there? Oh, that's not the middle. Right there. So a 6-degree mesiodistal angulation. That's not bad. And I don't think I've widened as much as I could. I think I want to move the canines out a little bit. If you look at this case straight on, these canines are a little bit tipped mesially. What I want to do is I want to go in there and tip the crown buccally. Just the crown, not the root. See what happens. So I'm widening here. We have 1.6 millimeters of buccal translation here. Let's tip this tooth buccally a little bit more. Is it predictable to move a canine this far buccally? Yes, it is. And what happens when you widen the arch like this? You create more space in the anterior. You don't need to do as much IPR. I can get these rotations now just by expanding the arch. Now that I've done that, let's see. Does that lateral look like it's in the right spot? Let's just see if we leave it in the same spot buccolingually. So no lingualization of the lateral, just rotating it. That looks a little better. Maybe we don't need 1.6 millimeters of buccal expansion on that canine. I'm just rotating it to make it look like a rainbow shape, perfect arch. Get those mesiodistal contacts edge to edge, balanced occlusion. Let's look at the occlusion again. I'm hitting on the lingual cusps of my upper bicuspids. What's the solution there? Expand on the lower. Watch that hot map change. Voila. Voila. Sometimes the cartoon will show buccal translation on these teeth, and in reality they tip buccally. And a little buccal tipping is not a big deal. It'll help with abfraction caused by lingually constricted arches. This patient does have a little bit of abfraction. That's why this buccal tipping is going to be helpful. You can see the teeth expand buccally. So let's see here again. That is looking really good. No IPR, good expansion. Are the midlines lined up? No. Poles were taken. It's widely known in orthodontics. Some orthodontists like to line them up every time, lower and upper midline. The only midline that matters is 8 and 9. Facial midline lines up. You want to make sure that they line up perpendicular between the interpupillary line. And it lines down the face. Everyone knows the Tom Cruise look where his central incisor is shifted 3 millimeters to the right. It always looks a little bit funny. There's a term for it. They call it the valley of, I don't remember what it's called, but it just looks slightly off and it drives people a little bit crazy. Someone can comment on what that's called in design. Anyway, so the manual controls are being utilized. I eliminated unnecessary difficult movements. I've also can control attachments. These upper teeth have attachments on every tooth. Number 9 has a double spike root angulation attachment, which are optimized. There's a little button in the plastic which will engage that the attachment and cause forces in the mesial and distal vector. Let me get my fingers here, like this, and it will help torque that root. Let's see, do I really need to torque that root? What happens if we double click and eliminate that? Let's see what the teeth look like. You know, I do want a little bit of a mesial root torque here because they do tip in a little bit, maybe just a hair. But I also know that if I'm using munchies, which help the plastic fully engage and touch the teeth, I may not need it. I'm actually going to delete the double spike attachment on number 8 and number 9. These attachments I'm not a fan of. Optimized plane attachments with munchies and good surface area contact with the plastic. I do not need optimized plane attachments. I'm going to delete those. Why do I not need them? Well, I feel that these type of multi-plane attachments, if the tooth gets off track even a little bit, actually get the plastic to sit way off the teeth and make the case less predictable, and they can get off track way easier. On incisors, this is my gut feeling. I've done 300 cases. I do not feel like I need optimized attachments when I'm using munchies to rotate these incisors even 24 degrees. I'm going to eliminate them. Notice my tooth movement assessment has not even triggered an alert here. Tooth movement assessment will trigger alerts if the algorithm thinks that the attachment's required for a difficult tooth movement. It's going to trigger it if I remove the teardrop attachment. I call these teardrops. They are huge. They're my least favorite attachment in Invisalign because they're so obstructive in the way. And I'm exaggerating here. Patients don't like them as much. I don't get a ton of complaints about them, but I don't like them. I think they look tacky. So I'm going to remove it and watch. Boom, blue dot shows up. That's a TMA alert saying that there's no attachment and they're trying to rotate a canine. I do want to put an attachment on that tooth though. And I'm going to put on a HBEV intrusion attachment, which is this one here. Why am I going to use this one? I'm sorry, I'm going to use the other one. Why am I going to use this one? Because I have control over the placement. I call this making your attachment sexy. I'm going to make it flush with the tooth to where the beveled surface, this surface right here, facing the gingiva, there is a ledge facing the incisal, and whenever the plastic hits that ledge, it's going to engage. This is an easy attachment for patients to remove the aligners on and off. The aligners kind of slide down and click off, and when you put the aligners back on, they slide up and kind of click in. They're good for anchorage. They help the plastic grab the tooth even in rotations. It's a very good predictable attachment, and it's not this huge teardrop attachment. I'm going to delete the one over here. I'm going to get the same alert. I'm going to put the same attachment over here, and I'm going to make it sexy. I'm going to move it this way. You hover over the attachment when you have the attachment cut highlighted, and I can click. Sometimes it's hard to click it. Click it, bring it in a little bit. I'm going to move my display over here so you can see this up close. Let's go this way. Zoom all the way in. Click, drag, eliminate that little ledge that was on the gingival side. Now it just snaps on and off. Really smooth, sexy attachment. Doesn't rub the lips too much. I also want to make my other attachments sexy. These are called HBEV, horizontal beveled attachments. The bevel's facing towards the gingiva is 3 millimeters. If you look up close, you zoom in, you see a ledge on the incisal side, you see a ledge on the gingival side. That will help luxate the tooth a little bit. It snaps over it. It's kind of a sharp edge. I don't like them on my HBEV attachments. I make them go away. If you want to be really nice to the patient, you use the ones that don't have a gingival ledge. Gingival ledges are helpful when extruding a tooth. In these cases, I have no extrusion, no vertical movement planned in my bicuspids. So I'm going to go in and put my favorite HBEV on. And I'm going to make it sexy. I'm going to slam it down, tip it back, slam it down, tip it back. On the lower arch, if we are trying to intrude lower incisors, which we're really not anymore, you definitely want an upward vector of force on the bicuspid, which will help maximize the downward force on the centrals. This is a physics thing that you can conceptualize. You want upward vector here, downward vector here. It helps intrude the centrals. If we're not trying to intrude them, you really don't need them. I'm going to leave these attachments on just for anchorage. Helps the aligners snap in and fit intimately against the teeth we really want to move. This lower arch really, we're not doing a whole lot. I'm going to eliminate a lot of these attachments. I'm just going to hover over them, right click, remove, We don't need these little lingual attachments. Those are called Galler anterior intrusion protocol attachments. They're very, very helpful when intruding the lower incisors, but in this case we don't need them. I'm also going to take away the optimized root control attachment. We don't need them. Really simple lower arch. Just anchorage attachments will do just fine. Let's move my face over so I can get up close and personal. Let's make these sexy. And voila, they look a little sexier. So already this case is starting to come together. I'm going to do these other ones here. You can see basically I've gone and made all of these attachments sexy. A couple other tools that I'm not going to have to use today. I'm going to show you guys in just a second. They're very, very helpful manual controls. Let's just make these sexier. Man, that looks good. These right here are called power ridges. Power ridges help torque that root lingually. They're helpful in root torquing. These are called bite ramps. They're very helpful in intruding and preventing a posterior open bite. In this case, I'm not really worried about a posterior open bite. I'm going to show you how to remove those bite ramps. All right, so let's go back to our presentation here. These are my crushing Clincheck tips, and I can send you, I have a Word file, I'll show you. Anyone who wants it, I'll email it to you. It's very helpful. It shows you how you can do this. But number one, you can zero out a tooth movement by double-clicking on the tooth modification table on the bottom. Excuse me, that's number two. Number one, you can right-click a tooth and make it unmovable. So not in this Clincheck, but in some Clinchecks, you'll get a tooth, and the algorithm will make, let's say they'll take this tooth number, and I click on the tooth number 6, and it'll do something really weird with it. Sometimes they groove teeth, which means they want to make the teeth fit in the groove. Like they'll want to make this tooth fit in this groove to look like a typodont tooth, and they do this wacky root torquing thing, unpredictable, gives you a black movement or extrude, and you're just like, what the heck do I need to do to reverse that? The simplest thing to do, you right click, make tooth unmovable, watch all these things go to 0, it zeroes the tooth out. It does create a kind of a whack-a-mole thing here. You see it zeroed all those things out, but it also did a bunch of other things. It added IPR or spacing to my case, did all these other things to my other tooth movements. You'll have to go in and manually move those, or you can do it in sequence. If you start from the back and move forward, you can right-click on teeth, make them unmovable, and it won't affect the other teeth as much. Now look, I totally changed my case and my outcome. You're worried, how do I reverse this? What did I just do? Not a big deal. Right over here, undo, tap it once. It undoes, does the last thing you did. You can undo until you go back to where you were. And voila, I'm back. If you get really dark in a rabbit hole in your case and you're like, man, where did I even start? What's going on? Go down here and reset. It's a really great thing when you're practicing Clinchecks or you're allowing your staff to practice their Clinchecks. They can do whatever they want. At the end, you hit reset. It goes right back to where that Clincheck plan number 1 was. Super, super simple. If you want to go and redo it, you can redo it. The tools are there. Invisalign continues to update Clincheck Pro and make this more and more manually controllable. Number 2, this is such a cool tip. You can zero out one vector of tooth movement. All you got to do is double click on the tooth movement table, type a 0 on your keyboard, hit enter, zeroes out that vector of movement. Like I said, the difficult vectors, the vectors that completely derail the predictability of a case, extrusion and intrusion, root angulation, and root buccolingual root torquing can derail a case as well. If you want to just simply eliminate that vector of movement, the vector here, you can either do it manually by dragging the little bar, or you can go over here and type in what you want or zero it out. I pretty much only type in 0. Otherwise, I'm very visual. I just get it to where I want it to be using the manual controls. Hope that makes sense. Number 3, you can maximize your attachments when placing them by controlling their position. You can make sure that they don't hit in occlusion. One big complaint, if you have a case and the attachments are placed where they're hitting when the patient's in MI, they drive patients crazy. You want to move them out of the way. You can totally move an attachment. You can move it all over a tooth like that. Just make it in a better position. I'm going to undo that and make it go back to sexy position. Really cool. And number 4, my big tip is staging movements for efficiency. I chose an easier case to show you guys so I can go through it pretty quickly. But for example, if I had a case and I really wanted to torque number 8, let's say I wanted number 8 to like do something wild. I wanted to extrude it, extruding a tooth, or let's say I wanted to intrude it 3 millimeters for whatever reason, improve the gingival zenith, open restorability, space for a veneer, whatever I chose. I want to intrude. That's a difficult movement. I can stage that movement to where I tell the tech, I type in the comments, please move all teeth except number 8 or 9, stage 1, stage 2, move number 9 only. You can do stuff like that and stage the movements. Invisalign, I'm talking to their clinical team. I got introduced to them last week. I really want to be able to do this manually. I don't want to have to talk to my technician if I don't have to. There is a staging page here which will show what stage teeth are moving at. On mine, all teeth are moving all the time. Except for molars, 1, 2, and 3, there's no movement. It's gray bar. Everything else is blue. It also tells when the IPR was scheduled. There's no IPR anymore. But this is a staging chart. If I can control this, if I could simply right-click that bar and say I don't want to move from 0 to 5 and type it in, it gives me full control. That's what I want. And I believe they're going to do it because they like me. And they're trying to improve the product. They're really trying to improve this to be doctor-led, not computer, not algorithm like Smile Direct Club. Or, excuse me, beep, other products. Now you're feeling like you're Neo. I love that movie. He gets injected with the knowledge of Kung Fu. When you start doing this, you're going to feel like, wow, you unlocked something. I now have control. You practice this. I do, like I said, hundreds of Clinchecks a week. So you'll get there. And number 7, this is a really important part. And there's some really good gems I want to share with this. It's communicating your tech. If you're married like me, you probably heard of the 5 love language books. Communication is very important. Poor communication leads to poor outcome. Early on in my practice, I was submitting Invisalign assist cases. Man, they were bad. My dad was my first case. It took us 2 years. The outcome wasn't good. I was frustrated. I almost gave up on Invisalign because the Clincheck was not predictable and I was letting my techs drive the control of the case. Do not forfeit control to the techs. That said, some things have to be communicated. And these are the 4 things that must be communicated to your tech. Number 1, smart attachments. If you want to add a double spike, first the movement has to be there, which will allow them to put the double spike, or the optimized G4 attachment, or whatever, the teardrop attachment. There's a whole series of optimized attachments, which I can share if people want me to. I have a presentation talking about attachments. But you have to ask for smart attachments. Smart attachments are awesome. They're proprietary. Invisalign is the only company that has them and allows them. I love smart attachments. Extruding lateral incisors using a smart optimized support attachment is so predictable now. I no longer say luck the laterals. I welcome extrusion of laterals now because of the smart attachments. Anyway, you have to ask for them, or the algorithm has to put them on. Number 2, overcorrection. If you want a case to have overcorrection, that is the virtual C chain, or at the end there's these aligners. They show up in black. At the end you see these, you go to your treatment plan here. At the very end, they'll have these little dark gray aligners. These are all blue steps here. The dark gray ones are overcorrection. They can over-rotate teeth. They can over-close the spaces using a virtual C chain. You have to ask for those. So you have to type them in the comments. Please supply, or please use overcorrection aligners at the end. That's how you do it. You just type it in. In cases where I don't use overcorrection, and let me just highlight this step, overcorrection is only allowed in cases that are spacing cases. I never ever overcorrect a crowding case, even if there's a lot of IPR. And the reason is, if you overcorrect and there's no space there to overcorrect into, you get these unwanted iatrogenic effects, and it can destroy your bite, derail your case, and then you're in a revision trying to correct the bite. It's a nightmare. Only overcorrect on cases where you have spacing. If you're using Galler spacing technique, you'll never take away too much tooth structure with the IPR. It's very, very predictable. Staging cases, like we talked about, if I want to do stage 1, expand from bicuspid to bicuspid, I'll put stage 1, move 5 to 5 only. And if I'm tipping molars, which is okay, I'll move molars, I'll say stage 2, move the molars only. Use the 6s by themselves. And what happens if you do that first 5 through 5 has good molar anchorage, and it happens predictably, and then it's anchored in there. Now 5 through 5 is anchored, and 6s can move predictably because everything else is anchored in. It's a beautiful technique. Staging is so important. Dr. Koenig has taught me a ton with this. Dr. Galler understands staging very well. I really recommend Reengage. You'll learn all this stuff. Number 4, and Reengage is an Invisalign course that Dr. Galler leads. Number 4, remounting. Sometimes a case will come back and it looks like, man, it looks crazy. It looks like, open bite on the back, and you're like, man, the photos don't look like that. What's the deal? They're closed in the back here. Well, maybe your assistant or you scanned it wrong, and the Clincheck got the bite wrong. You have to type in, please remount NMI according to the photos. You have to type that in. You type that in, they remount it, they get you another Clincheck back. No big deal, but you have to type that in. So those are the 4 things that you have to communicate. There are other subtle things, but for the basic clinician, that's what I want to get across. You can do things like having them trim the aligners. You can have them only cover 2 millimeters of tooth surface. You can have them give you Pontics and things like that. But in general, those are the 4 things you got to worry about. Pro tip, this is a really important thing. If you want your Clinchecks to come back quickly, be polite. And here's the rationale. If you start getting angry and you yell and you type in all caps and exclamation points, what happens is their quality control team has to oversee your Clincheck. So now when you submit a change, it goes through 10 different technicians, and you'll start complaining, what's the deal? My Clinchecks are taking 3 weeks to come back to me. And the reality is because you're being a dick. Pardon my French. Start talking to your assistants as your team. Treat them like such. I mean, this rule applies in life. Treat people with respect. Sometimes you have to type the same thing several times. It's okay. They have to understand and learn your language. The more cases you do, the more they'll understand you. If you rate them at the end of it, when you submit a Clincheck, it will say rate this Clincheck. Give them a 10 every time. My Clinchecks come back within 24 hours almost every time. And that's like, the more you type in, the longer it's going to take. The more angry your words are, the more people have to look at it. Be nice. Learn their language. Sometimes I even ask for my tech's name. I get a new tech every day. I don't know who my techs are, but I know I have a dedicated pod. I think I know my techs, but sometimes you don't. There's a lot of people. Invisalign's a $12 billion company, so can't expect them to have the same person dedicated to you. Let's go back to our Clincheck. So what do I need to type in this case? Not a whole lot. Let me undo my weird incisor thing here. It's pretty standard. Do I have any weird staging things happen on my video? I don't. If I had round tripping, you have to tell round tripping is a staging issue. Staging meaning they first tip a tooth buccal and then they tip it lingual. That's a bad thing for Invisalign. It's a great advantage of Invisalign over braces because there's a whole histological thing that happens when you round trip. I don't have to tell them anything with staging. I don't have to type anything in my comment back. This Clincheck is going to come back to my office in 24 hours. It's going to be amazing. So let's go to step 8. This is important. It's submitting a change. Once you submit the change, you're sending it off to Costa Rica for them to interpret the changes you made and send them back. If you are typing a lot into your Clincheck, it is sometimes a good idea to right-click the teeth that you want them staying in that same spot and you lock tooth position. If you lock a tooth position, it doesn't allow Costa Rica to move that tooth anymore. Sometimes I'll make everything perfect. I'll send it to Costa Rica and I'll just say something silly like, no IPR, or stage them like this, and they'll come back and all my movements are changed. If you don't like that, you type back, say, please revert to treatment plan number 1, and you go in and right-click and lock teeth position. If you lock a position, it makes it so they're not even allowed. They can't override that locked tooth. Anyway, I'm going to submit the changes. I like this Clincheck. This looks really good. Aesthetically speaking, number 7, I'm going to rotate it a little bit more just for aesthetics. And I'm actually doing it the wrong way. I'm going to manually just grab it, click it, drag it, and I'm going to move it buccally. I got to throw here for the rotation being over 30 degrees. My munchies are so good, I'm not worried about it. Incisors have a lot of surface area. That munchie pushes the plastic all over the tooth, buccal, lingual, everywhere, locks in the embrasures. It's going to rotate that tooth if I execute munchies well. Let's look at this overjet. Is this overjet an issue? Is this going to be a problem for the patient? Well, I look at my bite right now. I like to see some overjet. I have really good balanced occlusion distal to the canines. Am I going to have protected canine occlusion and slides? Yeah, it looks like I am. I'm okay with the overjet here. Some of you might not be. Let's say I want to close that overjet. I can click that button, left click it, except I got to go over here and say keep current, excuse me. Click it, add IPR. Click on here. I'm doing it distal to the canines to bring back some. This is really easy IPR to do. I like 0.4. 0.4 is a really predictable outcome. And let's see what happens there. I brought it back a little bit. I like that. I'm actually going to incorporate that. Maybe I'll even do a little more IPR back here. I'll do 0.4 distal to the canines to help improve the overjet in this case. You know, I even forgot. I'm going to actually type in that I don't need any bite ramps. What will happen with no bite ramps? What will happen is the plastic, when chewing on the plastic, will intrude the molars a little bit. It will cause the bite to close down a little bit more. That's okay in this case. They have a very, 1 millimeter maybe of overbite. The bite ramps, if there's overjet, sometimes they won't even hit on the bite ramps. I'm even torn on it. I use bite ramps in any case that's not an open bite case. This is almost an open bite case. Yeah, it's up to your decision. That's subjective. It really doesn't matter there. They're kind of annoying for the patient. I'm going to type in no bite ramps here. But you got to know, in this case, the molars are going to passively intrude. They're going to push in from plastic, from the patient chewing on plastic. It's called passive intrusion of the molars. Every direct-to-consumer product causes this because there's no bite ramps on any of them. ClearCorrect, Simply Aligners, excuse me, not Simply Aligners, that's a good company. Smile Direct Club, all these different aligner companies, all of these cases that are not open bite cases will end in a POB caused by passive intrusion. Every single one. That looks good. I'm going to submit the changes. Here we go. Rate, no comment. Less comments the better. Send it off. And now it's off in Costa Rica, and I'll get it back in 24 hours. So at first, when doing these cases, you'll start to see your Clinchecks. You'll go from doing 3 to 4 to 10 Clincheck revisions every time you get one back. It's okay. Back in 2010, it took me 5 to 10 Clinchecks before I was really happy with the result. Be patient. Do as many as you can. Let your staff do them. Dr. Koenig is a great role model of mine. His staff set everything up. All he has to do is hit submit. They know his systems. They know his theory so well. They understand the algorithms. He can spend all his time patient-facing on the things that really have impact on his practice, or his time with his kids. I can spend time with my kids, and I can do 100 Clinchecks a week. Why? Because I can do it on my own time. I'm getting very, very fast at this, and you can too. Be very patient. And this is the only kind of dentistry you can do sitting on the beach. And talk about assistants. You want to drive value to your practice. You want to make more than the ceiling. The average $20 an hour assistant can now make a ton more. They can be doing this for the doctors, doing cases that have huge ROI for the practice, especially if they're predictable. Doctors, they'll have value. The doctors won't want to lose you. You have real impact on patient outcome. And I think the ceiling will be blown off. I think we'll see the first generation. I think our assistants, Simply Aligners, Simply Forest Family Assistants, are going to see pay rates that are going to be higher than ever before for dental assistants. Same can happen with RDHs and hygienists in practice. Front office people can do this too. Anybody can do this if your doctor will give you a staff ID and you can start playing with it. It's really cool stuff. And lastly, when you get a Clincheck you like, you hit submit. It's a celebration time. It's time to see the success of your hard work. If you spend time to get the Clincheck right, you will save a ton of money. Most of my patients, more than 50% of our cases, patients come in 3 times. records, which is almost completely driven by a staff. The first visit, where I sit with the patient, tell them and describe what Invisalign is going to be like. I put on the attachments, I do the IPR, and then the last visit when everything comes off and we see if they needed a revision. And now my revision rates are 30-40%. That means that most of my cases are done in 3 visits. If you can get your cases done in 3 visits, your ROI goes through the roof. You can charge your patients less. We can make Invisalign more affordable, which will get your case number up. You can use it to guide and stage your restorative cases, and you can have huge impact on patient outcome. Patients are going to be thrilled. They're going to write good Yelp reviews about you like our patients have. They're going to love their results. They're going to allow you to present on your case. I have these cases I want to show where all these patients have allowed me to present. It's going to grow your business. Now you're going to start seeing patients' teeth like the Matrix, and that's happened in my life. I see patients walk in from Invisalign concierge, and they smile, and I see their teeth in Clincheck mode, like Neo sees the Matrix. And I can see, okay, I got to rotate that canine. I see it right away, and I can offer a predictable prediction of what the case is going to go like. I could say, you know what, this is going to be a difficult case, and I need to charge a little bit more for it. Or I'm going to have to use Propel or use Munchies to get the outcome I want. Or it's a surgery case. I know I'm not going to be able to get your chief concern because it requires Invisalign guided orthodontic surgery, which is a mind-blowing idea, and it's amazing. And we have an oral surgeon in town that's doing that. It's an incredible frontier in orthodontics. And you're going to stop non-tracking teeth like Neo stops bullets. It's really, really amazing. You're going to blow your mind when you start doing this stuff. And this is the time I'll do Q&A. I can't do it in this format, but I'm going to hopefully be doing more and more of these. Please submit questions in the comments. I will answer every single one. I'm dedicated to doing that. I have a few cases I love to show. These were all done in my practice. I finished them in May on one Friday. I called it a Finish Friday. I want to share. These cases were, just outstanding. I could share the Clinchecks too via email if people want to see them. This patient came to our practice being told he could never do Invisalign. He was never a candidate. He's a 47-year-old male. His girlfriend didn't like his teeth. They were yellow. They're stained. We did Invisalign. We did Propel. We did Munchies. I plan to do veneers. He has these weird laterals. They have like major voids. I'll show you here in a minute. You'll see it. But this case was so predictable. This looks like a difficult case. This is him after, before, after. Look at that arch. Widened, aligned. His teeth are no longer crowded. That perio issues. The gums are going to be easier to keep clean because he can now floss. He doesn't have these food traps he used to have. He now wants to do core whitening in my practice, and he's going to let me do veneers on these weird feet-shaped laterals. This is a dental anomaly. His smile, it looks incredible. It's wider. It looks like that Julia Roberts smile. His buccal corridor is now filled with teeth. His girlfriend thinks he looks sexier. He's super confident. He's 47 years old. He finished in 19 weeks. No POB, no revision. This stuff happens all the time. Patient's thrilled. This can happen in your practice. There's before and after. Look at the buccal corridors. Look how much wider his smile looks. Case 2. Very difficult case. Blocked out, inverted 3s, canines, tipped mesially. The hardest, most unpredictable movement in Invisalign in the past was rotating canines. It would take 5 revisions sometimes back in the day. This patient's 25, adorable patient, such a joy to work with. Had been told she had to take out her teeth, take out 4 bicuspids to correct her alignment. Because of Clincheck, I got to visually see what it would look like without extractions. And plan. I thought it would take extractions too, but I noticed if I did IPR, I maximized IPR. There's a lot of IPR, but I could totally align her smile within her arches without blowing through buccal plate. These teeth here are reference points. I know I can't, if I don't go further buccal than these canines, I know I'm in good shape. A lot of IPR. Plan to do some bonding at the end because she wore down her tooth. Look at number 9. It's all worn down and chipped because of her occlusion or malocclusion in front. Everything's collapsed on the side. This is her in less than a year. This is amazing. Look at those rotated canines. They are now aligned. This case was done in 11 months. Look at her beautiful before and after. I mean, this is like, to me, better than any veneer case you could do. It's her natural teeth that never touched her teeth with a burr. Just a little IPR strip in between. I did one revision. Did a revision. Look at that crossbite jumped on the lateral. Did a revision to improve the lateral incisor position at the end. It only took another 4 or 5 weeks. Patient's thrilled. She's doing core whitening, satisfaction level 11. She wanted me to present this case to our Austin aligner groups, and I'm super proud of her result. This is a direct-to-consumer case, came into our practice. Luckily, she noticed something was wrong. It was doing what it does, and it relies on an algorithm. It was just tipping every tooth out. And look at that fenestration on number 26. She was losing chunks of gum. She recognized it was a problem. She came to our practice, tears in her eyes, knew something was wrong. Look at the rotated canines up here. They are looking bad. I mean, that is a difficult crowding case. Gum recession gone. No more abfraction, no more gum recession. This is a massive change in her health. Talk about instant perio. My periodontist, I love him to death, can't believe that we're doing this. We're taking business out of his office. But, you know, this is predictable and this is sustainable. She's not going to lose this again because the teeth are in bone. They're anchored in bone. They required some IPR. Look at the canines now. We rotate them. Yeah, we could have rotated 27 a little bit more, but this patient's happy. No POB. Teeth are aligned. I gave her a big discount because she already spent $1,800 on the direct-to-consumer product. I charged her $3,800. Nowadays, I would have even charged her less because I'm doing this at scale at a faster pace. 20 weeks, 1 week wear with munchies. Predictable because of my Clincheck. So huge, huge upside with this case. Patient's a lover of our office. We gave her Viveras. She's whitening. She's a big proponent of Invisalign. And this one's a game changer, life changer. This case I love so much because the patient's a near and dear friend of mine now. I've watched her life change over the course of a year. She's so thankful. She had a baby mid-course, but she was told when she came to our office that she was going to lose a lot of teeth. They told her she was unrestorable. I mean, look at the caries. We have broken teeth. We have severe perio. The prognosis was poor. 37-year-old professional. She wanted to save her teeth, and the periodontist told her her best option was implant retained dentures. So she didn't want to go that route. She would do anything to fix it. We did a little bit of triage. We did gum therapy to remove the bacterial etiology. We did a little bit of buildups. We didn't do the crowns yet. We just wanted to build up, remove the decay, and then we scanned her for Invisalign. Look at the hyperplastic erythematous gingiva here. I mean, this is some significant perio disease. Abfraction, recession, everything. This 2012 before would have been all perio extraction surgery case in my practice. Now it's an orthodontic case. Look at her overjet. That's like 12 millimeters. I mean, she could stick her finger up in there. 15 months later, over a year, it would have been done in 11 months, but she had a baby mid-course, and we paused, and we revised her case while we held them in retainers while she went through a wonderful, healthy childbirth and has a healthy baby. But look at the attachment. Talk about perio success. Every time you see someone and tell them floss and brush, it's not because they're not flossing. Maybe it's because they're not flossing, but it's usually because of tooth position. Now their teeth are aligned, she can keep this clean. Do a little biocly here, or bonding, and you block out that space. She's going to be able to maintain good oral health. Now all I got to do is put a bridge here. Right now her retainer has a Pontic. She's very happy, but she's going to get a bridge or an implant there. Those arches are perfectly aligned. I only intruded and lingualized the teeth into better bone position. Look at the color of the gums. No longer erythematous. Little red here from my little Pontic on her retainer, but super minor. This is a life-changing case. And before and after, when she wears her retainer, that's blocked out. I should have taken a picture with it. But this is the kind of stuff you can do, and you can change lives. I am really excited to see dentists do this, and I'm going to start giving all the gems and tools away because I think the general dentist is the best professional in the world to be aligning teeth. I believe that the future is going to change this game. The algorithms are going to improve, but no matter what, a human being is going to have to interpret patients' concerns and diagnosis. Robots can't do what we can do yet. We need to learn from each other. There's a giant wave and opportunity here. Digital dentistry is going to just revolutionize the way cosmetics are done, the way functional dentistry is done. I hope you learned a lot. Please comment, please email, and yeah, align on. Thank you so much. Recording over.